Okay, so the first protocol we're going to talk about on change is the adult patient sedation and excited delirium protocol. Why are we having changes to this protocol? It's actually pretty simple, but I think you need to know the reasons why behind it. First off, we have a lot of issues with the ERs stating that the patients are coming in too sedated, and there's been a little bit of conflict on whether or not they need to be intubated. Seems to be that for the most part, these patients really do have patent airways and their oxygen saturations are good, but because the ER doesn't have the staff or such to monitor these people who are essentially sleeping off the ketamine, they feel the need to protect their airways. So there's been a lot of intubations that may or may not have been necessary, just from the point of protecting the patient. And lastly is primum non nocere, which in the Latin it simply stands for in the English, first do no harm. We want to make sure that we're not overly treating people that really don't need an extreme level of sedation when we're trying to just stop their combative behavior. So the focus of the ketamine arm of this protocol is really to control that combative behavior, to protect the patient and you as the crew and just the general public in general when these people get into these extreme behavioral combative stages. So let's look at the changes. The changes are specifically, as we look at them, on the adult algorithm, that the ketamine dosage and regimen has changed. And instead of being one dose, there's a potential for two now, and we've dropped that dosage, which adds in the need for a repeat dose if necessary if the combative behavior does not stop. We also added in that when we're dealing with sedating the combative patient, we really want them on oxygen irregardless of what the SpO2 reading is going to be. We are also adding in end-tidal CO2 as a mandatory addition to all sedated patients because we want to be able to monitor that and also kind of watch for that sedation notch that occurs in EtCO2 as well. So we can know that we've adequately got them into a state where we can manage them. So let's look at the actual protocol. And I've highlighted the areas of change. We look for the need of sedation, and we come down to that combative patient that's a physical threat to the crew, the public safety personnel, or general public. We have those two arms where you can really go with the midazolam arm or with the ketamine arm. The midazolam arm has not changed. What we have done is we have dropped the dosage of the ketamine to 2 milligrams per kilogram initially, IM. If you have an IV already established before they become combative, you have that option of 1 to 2 milligrams per kilogram slow IVP. And then if that doesn't work, which we believe most of the time it will, you will be able to actually repeat that IM dosage of ketamine up to a total maximum of 500 milligrams in 1 to 2 milligram increments per kilogram. So if you have an IV established, you may repeat it 1 milligram per kilogram IV once, because then we're in the 3 milligram per range IV, which is getting pretty strong in that IV range. What we have also added is put in the precautionary oxygen so that anytime we have sedated a patient for the purpose of ending combativeness, we are applying oxygen, and we have made the end-tidal CO2 mandatory. And these are just two patient safety steps. So if you have any questions regarding this protocol, please let me know and I'll get back to you. One last note, Dr. Gardner wanted me to mention in regards to the sedation protocol that she strongly feels, as does Dr. Stevenson, that ketamine is probably the best way to go with the sedation route. So if you are using the Versed, especially in times where you can't get close enough to somebody with a needle, they're very combative, and you're using the intranasal route, or if we're out of ketamine at the moment, make sure that you realize that that dosage range is for intranasal only. It is not for IV or IM on that on the midazolam on the Versed. So just keep that in mind and review that portion of the protocol. Thanks. Okay, the second change we're going to discuss is going to be to the unconscious / diabetic / altered LOC / narcotic overdose protocol, are kind of a catch-all for that arena. And we need to really discuss why we are having this change, because this one's kind of, in a way, very progressive to our system. So let's look at those changes. So we're going to look at two reasons. Number one, the literature actually for quite some time now has showed a lower normal range for serum glucose, more in the 60 to 110 range or 70 to 110 range than from the traditional 80 to 120 that we've already subscribed to. Secondarily, we've been working on a sobering center project where we may be taking some serial inebriates and possibly even later on some other types of patients to a sobering center to kind of alleviate the time frame we are tied up with these individuals, see some cost savings in getting the unit back quickly, and get them to proper care where they can get counseling before they're released. Well, the protocol for that sobering center actually calls for a range for inclusion of 60 milligrams per deciliter up to 250 milligrams per deciliter. So our treatment level when we're treating just by the number might have been in conflict. So we wanted to lower that from 80 to 60 so that we were in line with what they were doing with the sobering center once it opens. So let's talk about the changes here, and there aren't many on this one. There's going to be a shunt for hyperglycemia. I noticed while I was editing the protocol that there wasn't anything that said go to the hyperglycemia protocol for an elevated serum glucose level, so that's now in there. And then a range of change for treating the hypoglycemia by the numbers has really changed just a little bit to be more conducive to what we wanted. So when we look at the actual protocol, the only changes are in this box here, and that's the shunt for the hyperglycemia algorithm, and then a statement of if the serum glucose is less than 60, we really probably should treat it anyway, because there's some diabetics that do not show signs and symptoms until a lot lower. So if the serum glucose is less than 60, we want to go ahead and treat with a D10, 25 grams, or if the serum glucose is less than 80 with signs and symptoms of hypoglycemia, we want to go ahead and treat as well. And that's really the only change that we see there. The oral glucose was already in the right area, so we didn't touch that. So if you have any questions about the changes to this algorithm, just let me know. All right, that's it for the protocol update. If you have any questions, please let me know. I don't think I can say that enough. I know I've repeated it several times, but I want to make sure everybody's clear on what these protocol changes are and what they mean. With that said, remember, September 11th is coming up, so always remember, never forget, November 11th, 2001.